I would like to give you a very welcome to this Evidence Matters panel. On behalf of the mHealth Alliance, I wish to thank you, your presence, in this exciting 75-minute session in which we will address different perspectives on evidence of mobile health in mobile health. We will be hearing a very extraordinary speakers, and also I think that the topics that we will be reaching in this session are very important and very relevant for this moment. Before I will introduce the speakers, I would like to give some time to tell you about what is this evidence working group. This is a sort of network we are building with the support of the Mobile Health Alliance, and we have already organized around 12 groups that are working with a common mission to find, analyze, and synthesize evidence on mobile healthcare problems and applications, intervention. For this first phase of this evidence working group, it has been devoted, its work has been devoted to maternal and child health care, but we are looking forward to open the scope to different public health problems. So it will be important if any of you is interested in how look for evidence, analyze, and especially transmit and translate evidence for decision making. You will be happy to join us here. I hope that. So in this panel, we have some specific goals. I would like to ask for the first, please. So this is a welcome, a very warm welcome to you, everybody. And then the second one, please. The goal of this panel is to provide an overview of the status of evidence surrounding mobile health, offer multidimensional perspective. No, the other one, please. Offer multidimensional perspective on actionable pathway to improving the quality and quantity of this evidence, and we will give you particular emphasis that we need to place on work being done in low and middle income countries. The next one, please. The main topics that we would like to share with you are perspective on evidence by various stakeholders, from government, NGOs, funding agencies, mobile providers. Also, we will be happy to share with you some examples of efforts to generate and utilize and use relevant. This one? Use relevant. Oh my goodness. This one is? Examples of effort to generate and utilize relevant mHealth evidence. Also to identify this intersection between research, evidence, and policy that now is very relevant to do that, and what evidence resources are available for decision makers. Our speakers are Alain Labrique from Johns Hopkins. Perhaps most of you know him because he has been in the previous panel. Garrett Mell from the WHO, and Craig Friedrich from HSMA, and Sandhya Rao from the USAID. So each of them has a very important biography that I will give you. In every moment they will be presenting their work. Thanks again for this presence of this audience, and I will ask Alain Labrique to start with the first presentation. Is Evidence in mHealth, an Overview. And he is the founding director of the Johns Hopkins University Global Mobile Health Initiative. He serves on the faculty in the Global Disease Epidemiology and Control Program on the Department of International Health. His projects measure the impact of mHealth and other interventions on improving maternal, neonatal, and infant outcomes, with a focus on mortality in research-limited settings. I am very happy to introduce Alain. Thank you.
Thanks, Gladys. Thank you so much. So it's good that this is not a session on interoperability, because what we've discovered is that these clickers are too interoperable, and we've been actually changing the slides of our neighbors, and they've been changing our slides. So the last few sessions have been quite amusing to keep track of as we've gone along. So could we have the next presentation, please? Thank you. So because we're super geekish, we carry these tools in our bags, and so among the four of us, I think we have 5 of these in our pockets. So. No, actually, I'm not Craig Fredericks.
Alain.
He's much more better looking, I think. Nope, one more. Still not me. We'll get there. I haven't. 8, that one right there. Nope. Okay. So you haven't reached the level of fame of like a Jeff Sachs when they're still trying to figure out who you are. No, it must be the last one. No, that's not it either.
Maybe they attach them together.
Maybe try the first one. I apologize. Okay, let me just try. Maybe they appended it to the end of this one. If not, we'll jump to Garrett and then come back. Nope. Okay. It's not the PowerPoint conference, it's the mHealth conference. So if we did this with phones, I think we'd be a lot more efficient. So should we just take the first deck of slides that's up here and jump in?
Sure, I don't know if this is my part.
Or what, do we have a port up here that we can plug into, gentlemen?
Yes. Should I start?
Yeah. 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 It's better to wait for it. Great, great. Thank you, Alain. Hey.
See, it's almost like a TEDx talk. You get the speaker running up the aisle to the front. So keep a group in suspense. Well, thank you so much for your patience. So as global health practitioners, we face tremendous challenges. And for those of you who haven't seen this view of the world, it's done by worldmapper.org. And it's the world with boundaries inflated by the magnitude of the maternal and neonatal mortality in that particular context. So across these contexts, and I do have to go to the gym more often, we share several challenges, which include the high burden of morbidity, mortality, limited resources, weak public infrastructure, and a disproportionate population need to service availability ratio. And this is where these multiplicity of challenges have really, I think, found a niche in the mobile health space, which is why this conference has really scaled from a few hundred people to now over 4,000 or 5,000 attendees this year. However, there are historical concerns about e-investment. Last year we were privileged to have a meeting in Bellagio where we brought together groups of WHO and others brought together groups of leaders in the e-health space to talk about why is it that there's still consternation in e-health investments by governments and ministries. And one of the declarations that came out of this document was that e-health, if used improperly, can in fact do harm, but also can divert limited resources in settings which can barely afford to have this happen. But in the public health space, we have solutions. We have interventions of known efficacy that have emerged over decades of rigorous, robust, field-based research. WHO, the PMNCH have issued guidelines that discuss how it is we can save newborn and maternal lives with simple, not necessarily complex interventions at the point of care where and when these mothers and babies are dying. The packages of interventions are also well described across the continuum of care, from pre-pregnancy all the way to early childhood and adolescence. But the challenge is implementing these strategies at the community level, at the first level of outreach that's accessible to those individuals living in these rural communities, and at the referral district levels. The challenge that we face really is not what to do in many cases, but how to do it. And how do we get those interventions of known efficacy to where and when they need to be delivered for maximum impact? So many of you may be familiar with the correct criteria that is distributed by the ExpandNet at WHO. And these are criteria that are used to identify solutions, whether we're talking about interventions or health system strategies that can be scaled at national and regional levels. Solutions that are credible, that are based on sound evidence, solutions that have a relative advantage over what might be otherwise delivered using those same limited resources. And then finally, solutions that are testable, that can be demonstrated within a particular context, that address particular constraints in that specific population. Now, last year when we had this very same conversation about evidence and about perspectives, this was one of the slides that we showed from an excellent report that came out supported by GSMA and H.E. Kearney, speaking about the issues of perspective, that different stakeholders in this very complex ecosystem that is mHealth have different questions when they ask, does it work? Does mHealth really have the benefit that we tout it to have? And so we are faced with an issue of articulation. How do we speak to not just ourselves within the mHealth world, but with folks who are in the health world? How do we take the M necessarily out of mHealth and start talking about this as a way in which we deliver health? And so what we've found is health systems innovations is really a target language that we can use. Speaking about patient knowledge and self-efficacy, where these strategies are based on providing information, creating demand at the patient level, and developing support systems to help that individual function and manage their own care. But also speaking about strategies, mHealth strategies, that improve provider competency and increase their accountability for the services and care that they're intended to deliver at the community level. These can range from work management and workflow support, decision support systems, but simple tasks such as enumerating the denominator of the population you're supposed to serve can be critical in optimizing the reach and impact of a frontline health worker. And finally, strategic systems that allow systematic surveillance are critical breakthroughs that we've seen emerge in the mHealth space. And then thirdly, this pillar of health system adequacy. So managing supply chains, macro-level problems, staff and facility performance and reporting, and referral supports throughout the chain of referrals, where that frontline worker no longer works in isolation, but is part of a chain of strategy that goes all the way down to the tertiary centers. So this is a model that we've been working on through the evidence working group and through other mechanisms to try to bring together this language. How do we present mHealth to people in the health space, where we can explain how these measures, proxy indicators of success, whether we're talking about health information data quality, decision support, scheduling and contact monitoring, can all lead to improved care seeking, improved quality of care, and ultimately that golden target, the improvement of health outcomes. But really we find ourselves now thinking about how do we measure and convince stakeholders and investors that this is the domain which is really critical to focus on in the global health systems paradigm. So we really are talking about seeing mHealth as a health systems catalyst. How do we take interventions of known efficacy, which are challenged to get to that point of effective coverage, so quality coverage at the reach that it needs to have the maximum impact, when through this process of implementation, any one of you who have been in the field trying to implement interventions of known efficacy know that we run into potholes, failures to follow guidelines, drug or supply stockouts, lack of performance tracking. There could be 100 other potholes that I fill this trajectory with. But what we explain mHealth as is the ability to now patch some of these holes in the road such that we get to that effective coverage goal in a more optimal and efficient way. The other strategy is to take a claims-based approach to evidence, asking the stakeholder or the deployer of the mHealth strategy, what is the claim that you intend to make to your respective stakeholders, whether it be a Ministry of Health or a government or a NGO implementer? Are the questions they ask about cost, about risk? What is the risk involved in a failure of the system or of not having the system in place? Misuse of limited resources, inappropriate dosage of antibiotics, as we heard in a prior session. Are there policies in place to help support these kinds of strategies? What are the training needs that need to be in place prior to the implementation and scale up of these strategies? And then what are the alternatives to either doing a different kind of strategy or not doing this at all? And I think we have to think about ways of generating evidence about process efficiency, accountability, measuring coverage and quality, which are challenging sometimes to measure, but not as challenging often as outcomes that are distal in that timeline. So I think one of the things that we've observed in the past couple of years, especially in the last year, as the evidence in mHealth ecosystem has grown more robust, is a move away from this basic question of does it work? We're really asking what is the mHealth strategy? How do we articulate for each deployment, for each activity, what is the strategy? What is the underlying constraint that this approach is trying to address? Then the important question of, is the approach valid? Is there an underlying scientific evidence base that can support this kind of a strategy in the deployment of the mHealth system? And then, of course, we have several groups now working on developing strong indicators of success that can support the claims that are being made in that particular domain. And then, of course, the big question of how do we move from demonstration, or the dreaded P word that I won't use now, but you all know what it is, the pilotitis that we've heard, from that stage to integration, where these systems become the way governments choose to do, to administer their routine health care in a population. So there's been a flourishing of the evidence ecosystem, from the mHealth working group, initiatives that USAID has launched, empowering frontline health workers. Each one of these entities contains within it groups and individuals working on this question of evidence in this space. And I hope today we'll hear from a number of different perspectives about how that has progressed. But one of the things that is important to understand, when we think about framing evidence needs, it is important to think about what your target audience is. What is it you're trying to achieve? Governments are coming to informational bodies such as these represented here today to ask which policies, what does the evidence say about which policies we should develop and integrate nationally. Implementers, NGOs, are asking, what is the evidence for strategies that we can integrate into our health programs? And then the innovators, the researchers in the group, are asking, where are the gaps? What are the constraints that remain unaddressed such that we can invest our time and resources most effectively to ask the important questions? Now, we're thrilled because just yesterday we had a paper accepted in IJMI describing this shift in the paradigm of evidence in mHealth. There are, as of this week, and my colleague Lavanya Vasudevan did a lot of this legwork, has found 215 randomized controlled trials of mobile interventions being tested globally, registered now on clinicaltrials.gov, just as one source of information about how this ecosystem is shifting rapidly. So I want to leave that as an intro for the rest of the group, and thank you so much for your time.
Thank you, Garrett. You have pointed out so important questions that I think should be very helpful to open, when we open the floor, to see the reaction of the audience in that sense. For example, around these needs that we have today to translate evidence to the community, to have this kind of scaling criteria, and also to look forward to analyze in a better way this process that comes from the evidence implementation or intervention to the evidence implementation in policy. And I think this is important to have in mind. So our second speaker, he is Garrett Mell. Garrett Mell leads work on mobile health and innovations for reproductive and child health. He leads mobile health evidence synthesis through the WHO, the Mobile Health Technical Advisory Group on evidence, and they do a very good job in impact and scale in reproductive, maternal, newborn, and child health. Welcome, Garrett. You want to speak from here? Okay.
Got it. Oh, that's a good point, actually. Okay, sorry. Thanks to everyone, and thanks for your patience in getting everything up and running. We were recently at a meeting in Manila, and with a number of decision makers, a number of ministers and other programmatic and decision makers who reminded us that, in fact, there are limited resources and there's considerable risk to new investment from their side. So there is very much a concern from governments in general that they don't want to make a decision that they will regret about particular strategies and solutions. And it's important for us to ensure that the recommendations that are made to governments on what they should scale is based in evidence and information, in order to ensure that that limited amount of funding that's available is used wisely. The Manila meeting, though, interestingly, it enabled decision makers to meet with technologists and meet with program managers, and out of that meeting came the conclusion that that information and communication technologies can address and strengthen the delivery of existing validated interventions, and that we should look at it that way. And this is relevant to reproductive, maternal, newborn, child health, but it's relevant, I think, for the health care system in general. There was a recognition that it can improve the effectiveness of those known strategies, those validated interventions, and that the barriers to adopting and scaling, barriers to adopting mHealth are no longer the hardware or the technology, but rather it's the knowing what to invest in. Governments are demanding evidence. They see a lot of innovations in mHealth, and they don't know which ones to support. They don't know which ones to invest in, and it's a confusing field for them, as it is, I think, for all of us. So there is, though, a growing body of evidence that, that needs to be synthesized, brought together, and articulated better and disseminated to them so that they know what to invest in. I've cut the yin to the yang of Alan LeBrique's slide here. I've got the white one, and I borrowed it from him. And but it's an important point that there are governments look to these kinds of documents that WHO and others put out that are guidelines, and they are recommendations on particular innovations and interventions that that they know to deploy and they feel confident in. The governments, though, they don't know. They know that that they are having difficulty in deploying those interventions, and so mHealth is beginning to be seen as Alan has articulated as a way of delivering those innovations better, and that's really to make them more accessible, to make those interventions more accessible and more effective to the populations that are in need. WHO in general, as an agency, aims to support governments to make decisions about investments, and it also helps to distill evidence into usable guidelines and documents, and helps those governments also then bring them into programs and policies. Governments see value in evidence that comes from trusted sources, and they have particular types of evidence that they look to. They like to see, relative to another strategy, how much better is that particular innovation going to provide for what kind of investment. And mHealth, I think, is seen as that kind of an investment, and there needs to be a synthesis of that, this is a slide that others have put up and comes from an adaptation of the GSMA A.T. Kearney document, but it does note that there are particular kinds of expectations and evidence that's required in order for governments and regulators to support a particular strategy. I want to just sort of look to, though, to that evidence synthesis is really not on the project level in mHealth, and it's not on the platform level. It's really on the strategy level. We look to see to what extent a text message, for example, will improve the effective coverage of adherence to a particular drug, and enhance that and catalyze it, as Alan has pointed out. And mHealth strategies are made up of functions, use, and purpose for a particular constraint. Okay? So and the question that we have as researchers, does providing an SMS message as a reminder to take a drug lead to increased use? The decision makers themselves want to know, do those strategies improve compared to other interventions? Do they improve the effective coverage of those interventions in terms of effectiveness, in terms of cost, in terms of efficiency, in terms of utilization? We realized that governments were having a tough time understanding the role of mHealth, and I'm not sure that this particular figure in this size is actually helping to articulate that or help them as decision makers. However, what we've tried to do is to draw on existing known information sources to help them think through along the continuum of care, for example, along the health system goals that they need and they know they need to address as decision makers: improve maternal and child health outcomes, an efficient, cost-effective, accountable health system, and enabling access, delivery, and appropriate care. And we can look across the continuum of care, and we can look at these validated interventions, and we can see that there are a number of them that need that could be enhanced and catalyzed through mHealth, using particular strategies that are health system strategies. And then we've defined signal functions as an area that reflects the diversity of current use of mHealth to strengthen those health system functions and goals. And they reflect 10 areas. There have been a number of different groups that have worked on understanding the taxonomy and of mHealth strategies. And I think while this may not be the last one we see, it's one in progress. So let's look at a very specific project, and I apologize to my colleagues at CHAI, but their strategy in Nigeria is to use SMS printers for improving the turnaround time on HIV status among newborns in Nigeria. And the real question then is, well, where do they fit in on this document, on this figure? And we can look to see that they are trying to address management of childhood illness and HIV, using electronic health records and using communication, and supporting electronic records and trying to improve the time. So that's a particular strategy that we would be interested in understanding to what extent that would improve the timeliness of that strategy. So the mechanisms that WHO has in place, and we're trying to leverage those because this is the kind of thing that governments expect and see it as an objective, independent body that can provide guidelines and synthesis. This technical advisory group on evidence, impact, and scale in reproductive, maternal, newborn child health, it will have its first meeting in December with an attempt to look at the area and look at the evidence for specific strategies across the continuum of care and get that methodology in place and then begin the process of doing that synthesis and provide a way for us to be able to recommend particular strategies for improving the effective coverage of already validated interventions. We would like to be able to say, as a body, at the Technical Advisory Group and in general at WHO, that certain, an example of an illustrative statement that a Technical Advisory Group will make is there is a strong recommendation for the application of mobile phone short message service reminders for antiretroviral treatment adherence. That's the kind of statement that governments look to see and expect, and we hope to have a number of similar kinds of statements over the course of a review period. But the ability for us to make recommendations is dependent upon the quality of the evidence. And the higher the rigor of evidence, the stronger the kind of recommendation we can make. And so it's incumbent upon us as technologists and researchers to help to strengthen that body of information. So the objective, of course, would be to determine evidence-informed package of mHealth strategies that can be recommended for national adoption. And that on the basis of those recommendations, these are the kinds of things that governments should be supporting and financially contributing to, but also reimbursing and advising their partners in country to also come along for the ride and feel confident that these are the kinds of strategies that lead to improved health in the country. So thanks very much.
Thank you, Garrett. Very good thoughts around the way that we need to synthesize the evidence for government and decision-making in the level of government, and also important to see how we need now to pass on the conception of the evidence as part of a strategy, of a political strategy for the healthcare systems. And I would like to emphasize here that WHO has been starting with this evidence synthesis more than a decade. They started with the CD-ROM. I remember the first synthesis of evidence around reproductive health care. So I think that it's a very good example of what Garrett has given to us. And let us now give the welcome to Craig Friedrichs from the GSMA. He is the Director of Health. Craig heads up a dynamic team that is responsible for working with more than 1,200 GSMA mobile operators and broader mobile ecosystem companies to integrate commercially scaled and sustainable mobile solutions into the health system. Welcome, Craig, and sorry that I can't pronounce well your second name.
Thanks. You did very well, so thanks very much. Good afternoon, everyone. I'd just like to say that my presentation is far less scientific. It wouldn't pass the recommended tests from WHO, so I've had to rely on very cool photos and graphics and interfaces and slides, so I hope it suffices from our esteemed panelists. Just to pick up on what Elaine mentioned earlier, and I think is a crucial theme that is driving, needs to be driven through the session this afternoon, is that different stakeholders within this ecosystem demand different value drivers and the presentation of evidence in different ways. And that is critical when you consider how incredibly complicated the mHealth and broader health ecosystem is. Just to get a sense of that, if everyone could just raise their hands if you fall into a stakeholder group, who considers themselves based in science or academia? You raise your hand. Okay, and technology, private sector, health providers, 3, 4, 5, public health, NGOs, civil society. Okay, so far in ahead there are the scientific and academic community, and the perspective that we as GSMA want to bring to this conversation is a far more commercially focused conversation, and really driving towards the latter half of a number of evidence buckets that we presented last year. We mentioned that there was safety, efficacy, cost, health system, and adoption buckets of evidence that need to be put forward into the industry. And so we as GSMA, working with the 1,200 odd members in the ecosystem, want to drive a very strong message around cost, because we want to drive the value for commercial interests, increased revenue, market shares and ARPUs, and diversification of their portfolios into other areas, increasing their competitiveness, and so on and so forth. So let's get stuck in on that level. Anyone know what this is? No? David, you're not allowed to answer that. This is downloaded from, this is the US spectrum allocation for radio frequencies. Okay, if it scares you and you have no idea what it represents, don't worry, you're not supposed to know anything about it, other than earlier this year, that small red block in the middle was allocated for healthcare. It was set aside for mHealth. And that was specifically around data protection, interoperability, standards formulations, all those type of things that drive mHealth security and adoption into the health arena. So this, when we talk about evidence shifting the supply curve, the evidence that's been presented over the last 18 months, and definitely since the last presentation where we all stood up here, has driven the supply of mHealth in a significant way. Evidence shifting the demand curve. If you can't read all of those, I'll mention a few. What we've tried to do here is interview or survey a lot of the membership base of GSMA, asking who is involved in mHealth services and delivering mHealth services across WHO regions. Europe, 24% of mobile operators, representing 357 million mobile subscribers. Europe, 12%. Middle East, 37%. Asia Pacific, 37%. That was the highest percentage of any of the regions, which was fascinating to us. Africa, 10%. Americas, 13%. USA and Canada, 8%. And all of those have increased in double digits from 12 months ago, which is not, it should be interesting, and it should be fairly self-evident that. But the message there is that those double-digit increases in numbers are not necessarily increasing the impact on health systems. This is just something else. It's taken from the GSMA mHealth tracker. What is interesting there? It's just a little infographic, and this was released for the HIV/AIDS day on the 1st of December, showing that globally we're seeing 852 services. 247 of those were released across Africa. Remembering that we only have 10% of mobile operators in Africa involved in mHealth, pointing towards a huge amount of fragmentation across those services, an inability to scale, an inability to integrate into payment mechanisms, especially. So when we look at healthcare generally, we understand that 86 or 87% of all healthcare funding is in some form of reimbursed environment. In this type of environment, we're not seeing reimbursed payments for mHealth services at all. So there's a huge concern for us there, and something that needs to be driven in a very significant way through evidence. I'll make this available to anyone who wants that after the session. So this is the crux of what we're wanting to bring to the table and put before the broader ecosystem of partners in health and in mobile, is that when we're wanting to engage the mobile ecosystem, by that we mean the mobile operators, the handset manufacturers, the software developers, the marketing and digital companies of the world, and others who have a significant presence and reach and who we need in order to scale and create the sustainability, we typically have 3 points of evaluation or evidence that needs to be generated. And depending on who you're engaged with, that can either be demonstration of a brand equity, a support of strategic goals, or a much more traditional ROI, market share, ARPU, and other. And across the bottom there, what we've tried to show is that 1 year on from the previous year's panel and discussion, we're seeing a proliferation of CSR and CSI type of initiatives, in our eyes unsustainable and not scalable. Innovation, so this happening through new business development departments. We're seeing minimal evidence of success and value creation for those companies. And then on the commercial side, very, very little. I think a handful of companies that have actually got it right. I think WellDoc in the US were one of the very successful companies to actually get their services reimbursed, which was fantastic. We need more of those type of stories to be able to tell to mainstream mHealth more successfully. And so when we're looking at the future, what do we want to see 1 year on from today? Well, I think in terms of shifting the supply, GSMA recognizes that we have a very limited field within which to work. We have a very defined value proposition that we need to demonstrate to our mobile members, governments, the broader ecosystem, driving the ecosystem as a whole, but also realize that we don't have the capacity or the knowledge or the resources to do a lot of the work that falls on our shoulders out of necessity rather than qualification. So this year we worked with Johns Hopkins, Elaine and his team. We've been working with Garrett and WHO and others to take a lot of the work that has been done in those organizations and break it down. You saw the fantastic framework that WHO had put together, and the impact indicators that Elaine and his team are busy synthesizing and putting out into the market. We want to take those pieces and convert them into language which is digestible for the broader mobile ecosystem. And in order to do that, we have a number of resources, a number of outcomes, and I think the take-home message here is that GSMA is not looking to do this on their own. We're looking for partnerships. We're looking for relationships. We're welcoming a lot of help on a lot of these areas. And for many of you putting up your hands in the science and academic field, we'd love to have a discussion around how we can actually do that in a bigger way. We've developed online analytic tools through wireless intelligence, which aggregates all of mobile data for every consumer around the world. We can literally tell you how much you're spending on your mobile phone in any economy at any given time. So if we combine that with a lot of the health knowledge and overlay that with opportunity mapping, imagine what we can do in terms of prioritizing geographic regions and areas and disease conditions, and how we can target services to specific user groups more effectively. Mobile Development Intelligence is our big analytics platform. Our national repositories of information. So again, this is developing work out of necessity, presenting information to governments and regulators, both in the health and telecoms and science communities, to drive mHealth ecosystems and communities or countries where technology is being deployed at a rate far faster than any traditionally slower government or healthcare regulator could keep up with. But again, we need partnerships, sustainable partnerships, and vested partnerships that can help us deliver on these tools. And then driving the demand, our Pan-African mHealth initiative. We're quite proud of the fact that over the last 6 months, we've been able to negotiate with the 5 dominant operators across Africa, and that's to deliver collaborative mHealth services in all their markets. And simply sitting down with 5 people around a table, we were able to gain access to 370 million mobile consumers around Africa. So the potential of leveraging that through those 5 conversations is quite astounding. We've recently launched a diabetes initiative focusing primarily on Middle East, working with the WHO and ITU initiatives. And then all of the GSMA events and convenings obviously brings everyone together around the mobile ecosystem in a very strong way. So last message on there is we welcome any collaboration and interest to expand on that work and into the mobile ecosystem. Thank you.
Thank you very much, Craig. Your second name is from German? It's German? You can imagine, I have to tell you a scene because I have lived for 1.5 years in Germany. That means that I'm a very bad student there. I have been very bad student. Okay, let us now, one of the key ideas that Craig gave us is how now also the development of infrastructure and technology, hard technology, must be sensible to decision-making and to the concept of strategy, policy strategy, and how this can be facilitate more the link of technology, use of evidence, and decision-making. And I would like to quote one of the conclusions in the Belayo meeting last year. They say that our challenge today is to generate high quality and useful evidence and promote the appropriate integration of technologies to improve health and reduce inequalities. And I think this is a very good thought coming from your presentation, Craig. Thank you for that. And now I will introduce to Sandhya. She is Sandhya Rao. She is from the United States Agency for International Development. She provides strategic and programmatic leadership on private sector engagement in mobile health market-based solutions and social innovation. For over 20 years, Mrs. Rao has advised government NGOs and corporations on the design, management, and evaluation of global development programs and partnerships. Welcome, Sandhya.
Thank you. I'm going to stay
Okay.
here. It's okay. Can you all hear me? Is the mic? Great. Thank you so much, Gladys. So I was asked to talk about mHealth evidence from a funder's perspective, particularly from an international donor perspective, because in terms of funders, there are many funders of mHealth, as we have heard on this panel. So the state of, let's see if I can do this from here. Great. Current state of mHealth is beautiful. We have heard this analogy many, many times, 1,000 flowers blooming. We at USAID have seeded a lot of these flowers, and they have resulted in a lot of really interesting, innovative, dare I say, pilots that have had a lot of attention paid on them and generally tend to be quite well funded. The question that we have asked ourselves over the last couple of years in particular is sort of, okay, so what's next? There's a lot of great examples. How do we actually know, which ones to invest in? And is that even the approach? I mean, should we actually be always piloting on a very small scale for long periods of time with RCTs? By the way, I noted on Alan's slide of RCTs that there were 32 RCTs in the U.S. and 6 in Africa on the entire continent. Oh, that was 2 years ago, so maybe we have 8 now. So, I mean, I think RCTs are important, but also trying to understand what is the threshold of evidence for the variety of stakeholders that invest in mHealth, not only with that level of rigor, but also looking at different levels of evidence and information that are required. I wanted to just go maybe one level deeper on this issue around pilots, because we've talked a lot about sort of, 1,000 flowers blooming and pilotitis, et cetera. But we started to ask ourselves, so, why are these pilots or prototypes such a bad thing? I mean, we probably in global health with many new interventions have spent many, many years on sort of the pilot stage and the research stage. So why specifically for mHealth? And I think a lot of it has to do with opportunity, given the scale of mobile technology, given the opportunity to leverage the ownership of handsets, the penetration of mHealth. I started to think about kind of what's the difference between prototypes and scaled services, and I just put some thoughts up which you're free to argue with during the Q&A. First of all, I mean, proofs of concept seed innovative ideas and demonstrate potential. They have a high threshold for risk, particularly given the small scale and relatively small investments. As I said earlier, they tend to be well funded. The results, are inevitably context specific. This is not necessarily just about mHealth. This is about any kinds of development interventions. They are context specific. But what happens is when we do focus so much on sort of the impact side of things, we lose I guess, the opportunity to document the lessons learned and what is now being called implementation science. So there's little documentation on the context and the enabling environment. Often a pilot ends up being a dead end because there was never any plan for scale or sustainability. So it's not that the pilot is inherently bad, but that it wasn't built for scale at a starting point. So what does this mean in terms of evidence? What happens is that pilot results are often not generalizable. They're often not replicable or scalable, particularly if contextual factors are not documented or addressed. In contrast, scaled services, and in terms of mHealth, there are really only a few. These services have been built for scale, with scale in mind, both in terms of the technology platforms as well as funding. They tend to be integrated into existing health systems. Oftentimes they're led by country governments and local coalitions of businesses and NGOs. They've benefited from a strong policy and regulatory environment. They tend to be more user-driven in the sense of knowing who your target audience is, doing a lot of formative research and iterative feedback with that user group, changing and adapting and iterating on your mobile service so that you're constantly making sure that you're relevant. Scaled services require a pretty serious effort at marketing and outreach, whether you're targeting health workers or whether you're talking patients or communities. I mean, people need to know, that your service exists, and that can take a pretty concerted effort. Driven by a business model that allows for multiple revenue streams. So, maybe, mHealth at the base of the pyramid for low-income populations and resource-constrained environments, maybe we shouldn't be talking about a commercially sustainable model or fully commercial model, but maybe we should be thinking more about how we generate multiple revenue streams through corporate advertising, sponsorships, catalytic funding, partnerships with microfinance institutions, even user fees, although I know there's controversy around that. And then finally, again, the sort of implication on the sort of evidence side is that the scaled services require partnerships with multiple types of stakeholders. So as you've already heard from the other panelists, the evidence and the information collected should really support the needs of multiple investors and stakeholders, from the mobile operators to governments to donors, implementers, as well as all these other groups. So just, some thoughts around comparisons on why we tend to use the term pilotitis and why it seems to be so dreaded. I think, I've gone into this, and I think other panelists have as well. Next slide, please. Again, it can't be stressed enough. Next slide, please. Great. I guess maybe because a lot of the mHealth initiatives in low-income environments tend to be funded by donors that have been traditionally focused on public health impact, we tend to ask for data or evidence to be collected on public health impact without really understanding the needs of all of these other stakeholders. So I think, again, just this is reiterating what others have said, but we really need to make sure that we're building plans and encouraging data collection that is required by a variety of stakeholders and investors. Next slide, please. So over the last year and a half or so, since we as a panel were up here last year, there have been a few efforts, quite a few efforts actually, at greater collaboration and global learning. The first has been a series of meetings that have been called the Green Tree meetings that really have brought together, convened a group of donors to think through how we can more strategically collaborate and coordinate with each other, reuse digital health content and technology platforms, adapt what already exists, figure out how to have our systems that we have funded interoperate. And I think there's been some really great progress in this specific area, and if people are interested, we could talk more during the Q&A. Another development is really the mHealth Alliance convening power. They have convened an evidence working group, which some of you in the audience are part of, and a community of practice, so that we can sort of learn from each other, share lessons learned, and also methodologies around evidence generation. The other development is really just overall a global health community commitment to work together to scale and sustain mHealth. I think as mHealth matures, we're starting to see more and more funders in particular. They know more, they understand more, every day they learn more, but yet still not a day goes by when one of my colleagues at USAID asks me, where's the beef? What's the evidence? Why should I invest in this? So my message there is, we need to do more to continue building the capacity of funders to understand how to invest in this space, where they should be putting their money, why they should be taking money from somewhere else to put into this, and really, framing it as a tool to improve access and coverage to known, best practices and high-impact health interventions, as opposed to taking something from, an immunization program, putting it into mHealth, using mobile technology and mHealth platforms as a tool to improve efficiencies in immunization and coverage, et cetera, et cetera. So I think that a little bit of reframing sometimes might need to be done to explain that. Finally, I know that the mHealth Alliance, through the Health Unbound platform, as well as the mHealth Working Group and a USAID project called K for H, are working together to improve access. Next slide, please. To the literature, the gray literature, peer-reviewed literature, et cetera. So, a relatively recent development has been a collaboration around this platform, which is essentially a searchable database that will collect information on evidence, information on research that has been done of all types. This is sort of just hot off the presses, starting to take shape. And I believe the URL that has been reserved for it is mhealthevidence.org, so stay tuned for more information on that. Thanks so much.
Thank you so much, Sandia. I think one important issue you have said is how we engage funders to support the evidence searching and the way that we need to transmit the results of evidence to decision making, and this is a very key issue. I think most of the possibility we have there is to give information about impact and results and the benefit that this is coming behind. Okay, I would like very much to open the floor. We have almost 10 minutes to share ideas and questions, whatever. Yes, please. If you want to go to the mic there. Everyone who wants to ask a question or a comment, please. Yeah. Kia, you have a mic in the front.
First, for those of people who don't know these four people or don't know all of them, maybe 15, 20 people in the world who are advancing mHealth, those four individuals have probably done more than almost anybody I know. So thank you individually, and thank you for the panel as well. And we have gym classes for you, Alan, with pedometers. My question is twofold. One, is there any hope of getting the global health community to, since it's now 2012, to get over the idea that maybe ICT can be useful and join the rest of the world in using ICT just underneath its operations so you can actually measure things and produce data? And I don't expect you to respond in your official capacities to that. But my real question is, I just came from a conference called Techonomy 2 weeks ago, where I was the only kind of health-related person. Everybody else was IT. And everybody's talking about big data. Nobody used the words randomized control trial. Everybody was talking about evidence. Everybody was talking about rapid cycling of change. Everybody was talking about real user focus and knowing a lot about you individually, Alan, and your genomics and, just all this stuff about you. And we're at the edge of gathering enormous amounts of data for the first time in global health. Enormous amounts of data. We have huge computing capacity. You guys aren't talking about that, and I wondered why.
Do you want to react? Yes?
Thank you, David. Thank you, David. So it's a good question, and I think part of it comes back to the articulation and to the target audience that we're dealing with. We're dealing with a situation where we're looking at, in the 20 minutes that each one of us spoke, we had 28 maternal deaths take place globally. These aren't problem sets that are going to be resolved using big data. The solutions are simple. The solutions are strategic and have been articulated very clearly in terms of ways to empower frontline health workers to deliver care at the point where the crises are happening. And so I think the M part of the equation for many of us working in global health is a very simple piece of the equation. It's revolutionary, it's transformative in the ability for us to now address critical windows of time, which we never knew were happening before the advent of the mobile phone. Knowing when a woman goes into labor, such that we can dispatch an individual with the skills necessary to support that mother who's giving birth in a village hut in rural Zambia or in rural Bangladesh, is really the innovation that we're seeing in the mHealth space in that context. So when you think about our priorities of reducing global maternal and neonatal mortality, reducing childhood deaths, that's sort of why the alignment of the sexiness of the technology, if I can be permitted to use that term, is a lot lower than perhaps the high-tech genomic approaches that are currently proliferating in some of the conversations. But I think what we do recognize is that there's a need to maximize the utilization of quality information. There is information to inform our decisions in investing in mHealth that go beyond the RCT, and everyone acknowledges this. Stage-appropriate evaluation methods are critical. We want to know about usability, acceptability, functionality of systems, but we also want to know about process efficacy. We want to be able, as several panelists have argued, to go to an investor at the ministry level, at a government level, at an NGO level, to talk to some of these large NGOs and tell them, look, this is a way to get a bigger bang for your buck. You have per capita $12 or $13 to spend per annum. How will mHealth both affect your bottom line in terms of investment, but then what are the dividends and returns that you can expect from this investment, not just in HIV, but in HIV, TB, malaria, pregnancy registration, across the board. These are health system strengthening solutions that we really want to get behind at the level of global health.
Thank you. Thank you, Elaine. Garrett, want to
Yeah, I'll just briefly note, I think the NIH has done some really impressive work in the area of bringing in engineering and machine learning and things to big data. I think a lot of the work they're doing is very much future think in terms of the kinds of work that that health systems need in low and middle income countries. So ideally, at some point, we'll see those innovations entering into the space. I think the big data of mHealth in low and middle income countries is actually the kinds of registration systems and ensuring that there's accountability, ensuring that clients are, that health workers are attentive to clients and that events are taking place. So often the most vulnerable populations are missed. And I think that in those cases, you're seeing data in aggregate form going into reporting systems, and that is the big data that that countries in Africa and countries in South Asia and elsewhere don't currently have systems in place for, and mHealth can facilitate that and make it accessible to them. So that is the excitement of big data, if there is one, I believe.
Thank you, Garrett. Yes, second question.
Sharik Kocher from mHealth Alliance. Thank you very much for wonderful presentations. You talked a lot about scalability, and when we talk about scaling, it's not just the matter of evidence or financing, it's also the matter of capacity. And in many developing countries, you guys working and I remember people, and especially in the ministries who are making decisions, asking, yes, we know the evidence is there, we can use that evidence, but do we have enough manpower to do it? Do we have enough trained IT people to support these programs and things like that? And it has taken so long for educational institutions to respond. Even now you see few graduate programs in developing countries here and there on eHealth, but really working on mHealth would take a lot of time and getting people developed for these countries. So what are your views on that? How we can address this problem for scalability?
Thank you, Sharik. I would like to propose to hear the three questions, so you can, each of you can take one of them.
So my name is Eugene. I'm from Nigeria. I would like to commend Dr. Craig for the wonderful work he's doing with the GSM Alliance and the MOUs he's been able to put together with the providers in Africa. My question is that the African and particularly the GSM industry in Nigeria seems to be the fastest growing, so that is what evidence tells us. Yet, when you look at the presentation done by Sandia and what you've, considering the founders' perspective and what your group is doing, most of what we have in Nigeria especially is that the GSM providers there are just doing corporate social responsibility, small pockets of one-off donations, and not really investing in mHealth. What is your group, the GSM Alliance, doing in order to really encourage the GSM providers that are in your group of the MOU for sustainable funding of mHealth in Nigeria? Thank you. Or in Africa. Thank you.
Thank you for the question. And very short, the last one, because we are on time.
Yes. I'm from Guatemala, representing the Alliance for Nutrition. In Guatemala, we are 15 million population, but we have 21 million cell phones. So it's very, very big penetration. We have over 95% coverage throughout the country. So it's very well covered. Our Ministry of Health has, in the past couple of months, taken a great interest in mHealth. They are, and they really want to launch it nationally through their primary healthcare, to be their primary healthcare strategy, or for implementation of better services, data, information, etc. There are 2 or 3 point solutions in the country that are very localized, that are very not very profound pilots, but the stakeholders are very strong. And each one has now want to lay a stake in the mHealth environment, and now they want to rule it, quote unquote. What can be done to try to untangle this? I think there should be some normative. Thank you.
Thank you so much for the question. Who, our panel, would like to answer? Sandia?
I might just make a comment on the last question, Andres. Thank you for your question. Taking my USAID hat off, of course. I guess I would ask a question back, which is, has the government brought these different stakeholders to the table and indicated its interest in, what it sees as the way forward for the Ministry of Health and for the country? We as a funder in Guatemala and elsewhere, we support the Ministry of Health, and what we see as the path forward is ultimately for these information systems to be country-led and country-owned. So, at least from the funder's perspective, it would be interesting to see, what is the ministry looking to do in terms of creating a roadmap for how they want to scale up these either the existing pilots or something new. But yeah, that would be my first question back to the group is, who has taken leadership in the country to figure out what is the next step?
Okay. Thank you, Sandia. And Garrett?
Yeah, Sharik, a very good question. I think it's an excellent question in terms of the absorptive capacity of government to take on some of these systems. I think I don't know that we're going to see except maybe in the case of some countries where there's a strong IT infrastructure and a strong tradition, like you're seeing in countries like India, to take on those solutions entirely themselves. I think what we're seeing and what we're hoping is that countries actually institutionalize the kinds of practices. They make mHealth as a complement to existing standard practices for their health workers and at the different tiers of the system. And that then enables the opportunity for training, for the kinds of support that they need and the reinforcement that they need and the kind of motivational tools to actually be a part, to learn the systems as well. And in the case of India, just as an example, they have instituted not reimbursement schemes, but rather recurring financial investment in external partners who have brought those innovations to the table. So the 108 number, ambulatory care, was outside of government, and then it became a solution that was incorporated into it. But it wasn't, in fact, one that it's still, in fact, maintained by a private sector group, but it's being rolled out state by state. And I think we could see the kinds of providers, solution developers that we see in the room who are developing solutions at country level be partner to that kind of process where they're outside of government, but it's within the budget, and there's a line item for payment.
So just since we're on the same question, I want to just finish a response to Sharik's question. I think in the solution space, we also will see the stratification across client, provider, and systems solutions. And I think it's important not to confuse the discussion across those three stratum. Sometimes there will be cross-cutting interventions that affect all of these, but there are strategies that focus on the client and that focus on the provider, that the evidence base for which is growing rapidly. Looking at supply chain stockout management using mHealth strategies is one that I can imagine in the coming year or two we will start to see that being mainstreamed much farther beyond what it is already being used for today. The success of programs that have focused on supply chain management and the gains that those programs have accomplished are substantial, and I think that will really be a first aspect of supply chain and health systems innovation that we see going forward. But at the patient level, interventions that focus on adherence, focusing on behavior change such as a smoking cessation and diabetes management are interventions where the evidence base is growing rapidly. And RCT and non-RCT based evidence, I want to say, is really demonstrating the impact that it can have. In the HIV space, providing clients with a way to be reminded when to take a very complex regimen of ART is proving to be very effective in terms of the early evidence that's coming out of increasing compliance and adherence to those regimens. So across those three strata, we are seeing a growing body of information and rigorous evidence that will be pushing towards these systems being integrated as Garrett said, standard practice. And that's the golden calf that we're aiming to reach towards.
Thank you so much. I have to cut here because we are delayed in the ending of the session. Craig, do you want something? Okay. Sorry. I didn't know that you want.
This is what happens with private sectors. We always get never allowed the last say. Two things, very quickly. I think just to pick up on that capacity issue is that I want to throw a slightly different spin. I think we can take some lessons from mobile money and some of the other verticals of mobile. If you look at M-Pesa, just a quick stat, they transferred 20% of Kenyan GDP per month through Safaricom. I mean, that is phenomenal. And the reason they've been so successful is not only because they have a dominant market share of just over 80% in Kenya, but because they've got the fundamentals right of their cash in and cash out. And that's their agent networks. We're about to launch something in Indonesia which piggybacks their mobile money and Asia and agent networks to actually educate, train, facilitate a lot of the health workers. So there are non-health people doing healthcare work. So I would say that we don't need to train. We do need to, in addition to what's being said by previous panelists, is that we also need to think about disruptive, innovative ways of increasing the capacity, not only on the shoulders of governments and NGOs and health implementers, but let's start broadening our horizons. Let's start looking at mobile in general. And the prediction I want to make is that the scaled interventions, and this is a tweetable quote, the scaled interventions that we'll see in 2013 will replicate the successful mobile money implementations in certain countries. That's the prediction that I want to come and test next year. To Eugene's question, just very quickly, what do we do to ensure long-term investment from the mobile operators? We do two things. A phased approach. We work with development and health and government partners to identify opportunities, do formative research and product testing. We critically, within that period, we demonstrate value proposition for mobile operators, whether that's a tangible or an intangible value proposition. We then present that to the mobile operators and we secure a commitment across 4 different areas. We ask for their commitment in an MOU, binding MOU, their commitment to launch mHealth services, and their commitment is they will contribute resources, they contribute cost, and that's the discussion and negotiation around short codes, pricing, reverse billing, and so on and so forth. It's around them being able to share intellectual property. So when we talk about universal access to services, you can't do that with one mobile operator. We have to be collaborative across all mobile operators. So they have to be willing to share operational, commercial, intellectual property with us and other partners. And then they also have to share assets. And those are, again, their more traditional assets as well as their enterprise assets. And I'm happy to talk about those in more detail afterwards.
Thank you so much. Really, it's very good. Congratulations to our speakers, and many thanks for the questions of our audience, and have a lovely